leaves the lens cap on. So we'll probably just get through these first two sheets here, or as much as we can. But so this is something I've gone through with my medics at Schofield, and I think it's helpful for anyone who's screening patients, really, because, hello, it's one more set of eyes on a patient's med list to avoid potential interactions and risk factors that they might have for being on these medications. So especially if somebody comes in and tells you, I'm taking this over-the-counter medicine in this dose, if you know that that doesn't make sense, like if they say they're taking 400 milligrams of Tylenol, then you know that maybe they're actually meaning ibuprofen or something like that, because 500 would be a standard Tylenol dose. So even something as simple as that can help you when you're screening the patient, not only understand a little bit better about their medical history and what they're taking, but also maybe kind of help catch some of those things that could potentially affect the treatment decisions down the road. So just to get started here, this case on the front will kind of help illustrate the point, and hopefully that kind of help all of us recognize that some of these very routine medications that people are on that we're going to see commonly can very easily start to add up, and the compound effects from each of them can cause some pretty significant problems. So 35-year-old man, you can picture me if you'd like, okay? Comes to the after-hours center with 1 week of productive cough, fever, shortness of breath, fatigue, and chest discomfort. So already maybe you guys are thinking, what? This dude's got a cough, stuff's coming up, he's got a fever, he may have what? Yeah, pneumonia, right? So it could be other things, but that might be what we're thinking of initially. So he's had cold symptoms for almost 3 weeks. Temp got up to 102 yesterday, and then over the past 2 weeks he's also developed some upper back pain, some muscle spasm because of his persistent cough. Mucus and cough are also causing him to have decreased appetite, frequent nausea, and occasional post-tussive emesis. So post-tussive meaning cough, cough, cough makes him throw up. So totally reasonable, right? You've got pneumonia, you're not feeling great, you're on a couple medicines, now you've got some back pain, but his review of systems is otherwise normal. So really nothing else wrong with him as you're screening him. His medical history is important though. He's got chronic left shoulder pain. He had shoulder surgery 3 years ago, and he's also has a major depression diagnosis that he's had for the last 2 years. Both his chronic pain and his mood are controlled with medication. So this is another kind of way to illustrate why asking a medical history is important, because the medications that we use to treat those things or other symptoms that they have may go along with why they're coming in. So his medications include bupropion. Anybody know the trade name for that? Wellbutrin, yes. So Wellbutrin, 450 a day, which is the max dose. He's on that for depression. And he also takes tramadol, 50 milligrams up to twice a day for his chronic pain. About a week ago, he went to a different urgent care because of his back pain. At that time, his cold symptoms weren't really paramount in his mind, but they gave him Flexeril for his back pain, 10 milligrams at bedtime. And then he's also taking the Dayquil, NyQuil type stuff during the day and night intermittently to help with his symptoms. You screen him up and his vital signs are written there, all right? So what do you notice that's abnormal there? Temperature, yep. He's got a fever, what else? Heart rate's up, yep. SpO2 95 is probably a little bit low for somebody his age, but that's not necessarily an urgent or emergent thing. But those are things that when you're sharing this patient with the provider, you're gonna highlight those things. You're gonna say, hey, this dude's been here, he's here for 2 weeks of a cough, it's gotten worse, now he has a fever. You know, those are things to highlight to the provider so that the attention kind of comes to the more significant reasons that he's there. So you're looking at him. This is something we also, just to kind of get an impression of patients, is you're looking at him when he comes in. Is this dude sick or not sick? If somebody comes into the door and they look like trash, we may intervene a little bit sooner and either get them treatment started or determine that they need to go to the ER. So you guys, as the ones that are screening the patients, this is really important to just kind of get comfortable with, hey, if I'm looking at this person and that's my sister or my husband or whoever looks like that, they look sick, right? So this dude does not look sick, but he looks tired. He's breathing comfortably, but when you or the provider listens to his lungs, you do hear some crackles, right? Otherwise, his exam is pretty normal. So we get a chest x-ray and it looks like that. What does that look like to anybody?
A chest x-ray.
Yep. So you've got that big white blob down the middle, right? That's the heart.
The heart.
And then on that left side, which is our right-handed side of the paper, you see that big white something out in there that shouldn't be there, right? So that's what pneumonia looks like. So totally reasonable story. This guy's had a cold for 2 or 3 weeks, cough's getting worse, now he's got a fever, and his chest x-ray looks like that. So most people are gonna do okay with treatment. Send him on some antibiotics, send him home, and go from there. So your provider appropriately diagnoses this person with community-acquired pneumonia and nausea. Nausea and vomiting are common symptoms to have with pneumonia. And as you're given this patient the ABS, you notice 2 new prescriptions. Azithromycin, which is what kind of medicine?
Antibiotics.
Yep, antibiotic, good, like a Z-Pak. And Zofran for what? Nausea, yep. You think back to this lecture, and the light bulbs go off, and you quickly say to the provider, hey, sir, ma'am, can I just run something by you? I noticed this patient's medications. So now we've got this person on Wellbutrin, Tramadol, Flexeril, NyQuil, Azithromycin, and Zofran. Okay? That's totally a reasonable combination of drugs that somebody could be on in this situation. You're on a couple of chronic meds, you get sick, we give you routine medications, and then something bad happens, all right? So that's why the med rec that you do when you're screening a patient is so important, to get that information accurate. Because I'm gonna have to do it, or Dr. Fernandez or whoever else is gonna have to do that med reconciliation anyway to make sure that it's correct, because that's gonna adjust our treatment decisions. So the more accurate you can make that when you're screening the patient, the better. All right. So, next page. You'll see some little symbols kind of throughout this thing. It is not designed to be an all exhaustive list, all right? A lot of these medicines have different side effects. Some of these medicines are more likely than others to cause these side effects, but if you look down at the bottom of the page, you'll see increased risk of arrhythmia. What's an arrhythmia? What's that mean? Heart, yeah, heart, basically an abnormal heart rhythm. And then the little star there, increased risk of seizures. So heart conduction problem and seizures are 2 significant side effects of medications. Obviously, there are a lot more side effects of these drugs that are potential, but those are 2 very important ones. And that combination of medicine that we just gave him is basically 4 drugs that increase the risk of seizures and 5 that increase the risk for arrhythmia. Things that you may not necessarily think about, but in combination can be super dangerous. So we'll kind of go through this list and talk about things as they come up, but this is a 35-year-old guy who's otherwise healthy. He's got some chronic pain, he's got depression like a lot of people, and we just gave him a combination of medicine that could kill him. You know, we had a older woman not too long ago who came in for one thing, we gave her treatment for it, and then she's admitted the next day with GI bleeding. You know, totally appropriate treatment that she got, but it's just a side effect that we need to know about. So the first one, and this is a common complaint that we'll see, is pain. All right, so the NSAIDs, ibuprofen, naproxen, there are a few names there you might recognize. Who knows what the max dose per day? Like, let's say prescription strength 800 milligrams ibuprofen is dosed how many times a day?
3.
3, good. Yeah, 3 times a day. What about naproxen? 500 milligrams, up to how many times a day? If it was 3, I wouldn't have put it on here, so it's a different number. Every 12 hours, right? So twice a day. Yep, so twice a day. And then a medicine like Mobic or Celebrex is once a day. Yeah, you could do the lower dose.
Yeah. Okay.
But the point is that ibuprofen is going to be dosed more frequently. Naproxen is up to twice a day, but there are options where you would only have to take it once a day. Right. Toradol that we give in clinic is in that same drug class. Sometimes I say it's like fancy ibuprofen, but it's not a by-mouth medicine. I think in other countries it is, but not here. So how do we give Toradol? IM or IV. Yep. The big distinction there is that the max dose is different, so we can't give 60 IV, but you could give 60 IM. That'd be kind of the max dose of that. Again, that's why this is important. If somebody comes in and says, yes, I've been taking Tylenol all day, and we decide, okay, well, I'm going to give them Toradol. Well, what dose of Tylenol were you taking? They say, well, I've been taking 800 milligrams 3 times a day. You're going to think, that's not a Tylenol dose, that's an ibuprofen dose. And if they've actually been taking that 3 times a day, then we're not going to give them that Toradol. So that's why asking what medicine you're taking, what the dose is, and what you're taking it for are important. Because that's something that you'll catch. If you ask them, what have you been taking to help with this, and they tell you 800 of a Tylenol, then you know that we need to kind of clarify that a little bit further. So some important things about NSAIDs: widely prescribed, available over the counter, safe for a lot of people, but not for everybody. A lot of the bad side effects that you hear about or medical dangers that you hear about are actually from NSAIDs. So what's the general age cutoff for kids for ibuprofen? Anybody know? 6 months. Yeah, 6 months of age. It's actually okay younger than that. Like in inpatient settings, NICU settings, they will routinely use NSAIDs in kids, but just as a rule, just don't. Just use Tylenol. It's going to be the safest for kids under 6 months of age. NSAIDs don't use in preggers, okay? Again, I put the note there, technically it's safe second trimester. So first trimester and third trimester have kind of some reasons to not use it, but just as a rule, just avoid NSAIDs in pregnancy. And then, can anybody think of specific patient groups where you might want to avoid NSAIDs? Kidney disease we have on there. How about the big group that's always at risk for everything? Older people, yeah. So avoid in elderly patients. Not only because probably their kidneys aren't working as great, but also they're typically going to be more sensitive to medicines, and they're more likely to be on more medicines that might interact. They might be on blood thinners, they might be on heart medicines. And then adults with asthma, which I thought was interesting. So up to 10% of adults with asthma can have an acute exacerbation from NSAIDs.
Interesting.
Which, if you consider how many adults take NSAIDs, that's kind of a lot. Bad asthma in adults we don't really see a lot. It's mostly in kids. But even in my active duty population, I've got several soldiers who have asthma, and as you can attest to, that's the medicine of choice. Everybody gets ibuprofen in the Army, right?
Taking off the mission lost our team.
That's right, 800 Motrin Ranger candy, right? Okay. So, but that's really high, 10%, which I didn't know. Yeah.
I'm not in that.
So even from the first day of use, meaning this is the first time I've ever taken this medicine, my first dose, I'm at an increased risk of GI bleeding. GI upset, yes, it can cause upset stomach, but GI bleeding more significantly, heart attack, and stroke. So we say, oh, we're just going to give them some ibuprofen. Well, even if I'm prescribing ibuprofen, I still mention these risks and side effects, because the one person I don't tell is going to have a bleeding event. We need to know about it. So that's NSAIDs. As a rule for an acute injury, like I sprained my ankle over the last couple days, NSAIDs will probably work pretty well. If I've had chronic back pain for years, this may not be as effective. These are anti-inflammatories, as the name would suggest. Any questions about those? This is not designed to make us all experts on these medicines. It's just more to kind of highlight some important features and familiarity of dosing and names. So when you see these things come through, you say, oh, this dude's on Mobic. Okay, I know what that is, meloxicam. He should be taking that, once or maybe twice a day. But if he is, then we shouldn't give him a Toradol shot. All right, other types of pain medicines. Tylenol. Everybody knows it, everybody loves it. If somebody has a Tylenol allergy, just be suspicious, but it's technically a possibility, okay? The max dose is what? Does anybody know in a day? how many milligrams?
4,000.
4,000. If anybody tells you it's 3, fight them. It's 4. All right. This is a very commonly overdosed medicine, both intentionally and accidentally. A lot of the prescription narcotics are combined with this, and so for people who are using those or abusing those or taking over-the-counter cough and cold medicines and they've got a headache, so they take a handful of Tylenol, super easy to overdose on this. So if you take not more than the maximum, it's very safe, but this is a common one that's accidentally overdosed on. So that's why some of the guidance put that down to 3,000 milligrams per day, just so that we have, you know, a little bit of wiggle room there. So max dose is 4,000 milligrams per
Mention
day.
about that, you gotta think about combo drugs.
Mhm.
So sometimes you have somebody on Percocets, right? They're getting acetaminophen from their Percocets, or they're on cold medication, over-the-counter stuff. Many of them have acetaminophen. So if you're adding that on to the Tylenol, that all kind of goes into the 4 grams, okay?
So for older people who may be on scheduled Tylenol, they're taking it 4 or 3 times a day. I always give them that guidance. Make sure you tell everybody that this is a medicine that you take, because, you know, if you're going to get something, ask the pharmacist. You know, if that's a prescription medicine because you're recommending it every day, that needs to be treated like a prescription. Because some people will just downplay, oh, I take Tylenol for headache, but all right. So it can cause blank failure in overdose. This is kind of the main risk to know about taking too much Tylenol is a particular organ failure.
That's liver.
It is
It
liver,
is.
yes, yeah. It is hepatotoxic, and it's not right away. So if somebody hits the ER and they've overdosed on something, we're gonna check their Tylenol level, and depending upon where that is, depending on how long ago it was that their overdose was, you can kind of expect the direction that's gonna go. All right. Tramadol. Our patient in the case was on tramadol. You see that's got a star and a dagger. All right, both an increased risk of heart conduction issues and increased risk of seizures. Some of these medicines through here, you'll see that an abrupt withdrawal from these medicines, meaning they're stopping taking them, can cause a seizure, or some of them, like tramadol, can just lower the seizure threshold, meaning it's more likely to have a seizure. I've only had one patient who I prescribed tramadol who had a seizure, and he was an active duty soldier, and he didn't disclose to me that he had a history of seizures, because he wouldn't have been able to get in the Army if he did. But anyway, it does happen.
Really? Wouldn't you be able to get in the Army if you did?
Correct.
It's not,
Seizures after age 3. Yeah, non-febrile seizures after age 3 is a no-go. Yeah. Or
not just controlled seizures.
right, if you're on seizure medicines, you're not going to get a waiver. Yeah. Actually, I think it's older than 3. Maybe it's anyway. There is an age cutoff in childhood. Yeah. So this can increase risk of seizures we just talked about, especially if taken with Flexeril. All right, we're going to talk about that drug later. But Flexeril is also a medicine that he got from the urgent care. Just a, hey, take this for your muscle spasm. They both carry those risks, but also structurally they're similar. So both these drugs are built in the same way. The chemical makeup is of tramadol and Flexeril are similar. Lidoderm patches is kind of my go-to for back pain, but it works best if you can touch the pain. So if it's a deep pain and it's back pain, they say, hey, it only really hurts when I do this or move this way, it may not be as effective. But if there's a spot on them you can push, then Lidoderm can be helpful. It's just going to numb that local area. I was doing ER medicine on a reservation, and a woman came in, older woman in her 70s, was complaining of full body numbness, tingling. And the attending did a good skin exam and found out that she was kind of doing the Macarena with her Lidoderm patches. So she had 8 of them on.
Oh my gosh.
The backstory is her daughter was stealing and selling her narc, so she didn't have pain pills, so she had to keep putting Lidoderm patches on. But anyway, so obviously even something like lidocaine in excess is a bad thing. But she had started to have EKG changes because lidocaine is a medicine that's sometimes used for management of heart arrhythmias, but in some of the ACLS protocol. But anyway, So yeah, we took her patches off and she was fine.
Simple fix.
And then gabapentin, you'll see a lot of people on gabapentin. Gabatine, some patients, I need my gabatine. But anyway, it's can be used for acute or chronic nerve pain. It's also an older seizure medicine, but kind of a safer alternative for some kinds of pain management. And it works differently than all the rest of them. So this might be your fibromyalgia, it might be your diabetic neuropathy, it might be chronic nerve pain after an injury. And then the opioids, everybody's favorite, down at the bottom there. Oxycodone, brand name OxyContin. When that's combined with Tylenol, like Dr. Fernandez was talking about earlier, it's called Percocet or Roxicet. Hydrocodone is generally considered a little bit more mild than oxycodone, but they are different drugs. So some people may have a sensitivity to oxycodone and do okay with hydrocodone. But this is your Vicodin or your Norco if it's combined with Tylenol. And some of these, I don't see it often, but some of these are also combined with NSAIDs. And then codeine's a little bit weaker, sometimes combined with Tylenol and like a Tylenol 3 or that codeine cough syrup that we have to prescribe. Opioids should not be used to treat what kind of pain? This is kind of a guess what I'm thinking question, but chronic pain is the idea. With the exception of maybe a cancer patient, chronic opioids is a bad day. The research says that even after a few days of using these medicines, like after surgery, which is a reasonable thing to do it, that you're at risk for abuse and dependence and misuse even after a few days, because these work on brain chemistry and they affect how our body perceives and reacts to pain. So even not taking these medicines can cause kind of a pain response. But some typical side effects, obviously risks are abuse, dependence, but constipation and itching are kind of side effects of these medicines. And then contributing to one of the, they talk about the opiate crisis or the opiate epidemic. What's the street drug that's similar to this, that works on the brain like this?
Is it heroin?
Mm-hmm. Heroin. So sometimes it's easier to get heroin than it is Percocet. So people will have a bad surgery or a bad injury at work. They're on Percocet for 3 months. They get hooked. Their doctor cuts them off, and so now what do? They go looking for something that works the same on the brain.
I was on Percocet for 10 days and afterwards I was for crazy.
Yeah.
Had a bone surgery
Mhm.
on my jaw. Withdrawal sucks.
Doesn't take much. All right, so then the last little category of muscle relaxers, cyclobenzaprine. My triple Z's in the middle there is just my kind of like cue to remind you that it's a very sedating medicine. This is given at bedtime. It can be dosed up to 3 times a day, but for most people that's going to be sleepy time. So, but you'll see the star there. So that's the one that's structurally similar to tramadol and can increase your risk of seizures. Notable about this one is the half-life. Who knows what half-life means of a drug? Anybody?
How long it takes to get half of it out of your body.
Right. So if I take this drug right now, in how many hours is half of it still going to be working in my body? So a long half-life means this drug's going to be working for a long time. A short half-life means that it's going to have to be dosed more frequently or it's going to wear off more quickly. So depending on the formulation, Flexeril can have a half-life of up to about 32 hours, which means that even after taking a dose a day and a half later almost, still half of it's working in your system, but about 24 hours. About 24 hours. So you can imagine if you were taking this every single night that it could add up a little bit over time. Compared to Robaxin or methocarbamol, which is better for daytime use, it's not as sedating, but it also wears off quicker, and it's about 2 hours. So Robaxin you may need to dose about every 4 to 6 hours for it to be effective. But the flip side of that is you're going to be probably more functional during your day. And obviously both of these can be sedating, and you want to tell people to be careful about operating heavy machinery. But Flexeril I pretty much only recommend at bedtime for that reason. All right. Any questions about the pain drugs?
No questions, I just did wanna make a few comments, make sure we talk about over-the-counter when doing med rec. Looking at some of these on the list here, it's very common, not so much, the paresthesias you were talking about, but I have definitely, people just don't report over-the-counter stuff, it's like they don't think it's important, but Salon pos is like really common in our population, and so that's the topical lidocaine. So all of these, you should just make sure you ask about over the counter. It's really important that we will know if they're on something with some sedation already. And we're double checking, obviously the providers are, but it's so helpful when that's done already accurately. I think there was one more comment, I'm sorry, I can't remember it.
And even vitamins and supplements, certain vitamins and those are the kind of things will make bleeding more likely. So if we're doing a procedure on somebody and they're taking a baby aspirin and they're also taking vitamin E and they're also taking St. John's wort or whatever, that is going to probably affect if we how we benefit them. So
my other comment was about the PDMP. So many of these categories that Dr. Bain was talking about are going to be reportable, right? And I'm not sure why we all have, maybe why we all have separate passwords for that, because we can't really change what is on the website and what's reported. That's the pharmacies do that for us. But I think if you don't have access, I encourage you to, I know room 1 has my password in there. Every time I open up PDMP, I just get through. So that's a easy way if you guys are, gonna help out a provider, that they're giving away some oxycodone or whatnot, or you just get vibes from the patient that you feel this patient might be overusing narcotics, to go ahead onto the PDMP website. I feel, it's a tool that we never really had up until, more recent years. And so we might as well use it, right?
I think part of that's because it's required now. If we're going to prescribe a controlled medicine, we have to submit a query to that database. And so it's a way for them to audit us potentially if they see that we prescribed a medicine, but we did not log in and actually look up that patient. That might be why we can't have our own logins. But all right, so this is also a very common class of drugs that people will be on, both in my day job, in the military, and also in our general population. People have joked that we need to put SSRIs and statins both in the drinking water, add it to our fluoride just to make everybody happy. And the truth is, a lot of our water is also already testing positive for SSRIs and birth control just because of the frequency of use. And anyway, it's the circle of life. But so this class, SSRIs, has both that dagger and star. So these are both risk factors of increased risk of seizures and of arrhythmias. In general, these medicines can all be used for anxiety and or depression. There are other indications for them, also off-label indications, but as a general class, these are anxiety and depression drugs. Paxil tends to be more sedating, so this is one that I'll like to start people on, start men on at bedtime if they have trouble sleeping as part of their depression or their anxiety. And if I specified that I use this pretty much only in men, you might guess that the bottom says do not use during what 9-month period of a woman's life might fall there. Pregnancy. So the research looking back says that Paxil is probably not any more dangerous than the other ones during pregnancy, but it still carried a Class D classification back when we were using those pregnancy categories, and so it kind of got a bad rap. And there are plenty of other options, so there's really not a reason to start a childbearing age woman on Paxil, because then you run the risk of this woman stable on this medicine for a year and now she gets pregnant or is trying to get pregnant. What do? Do you force her to stop taking the medicine? You try to switch her medicine. You put her in that moral dilemma of, do I stay on this medicine that's working for me, or do I risk birth defects to baby? So while that's still a conversation to have with moms and their pre-pregnancy counseling. If they're all on a Zoloft or a Celexa, that's just a safer discussion to have with them. Say, if you do get pregnant, I want you to talk with me or talk with your OB about coming off of this medicine first, but this would be a safer option for you to be on if you do get pregnant. So Zoloft, there are only two. Zoloft is one of them that's also FDA approved for the treatment of PTSD. Again, a lot of these medicines we use off-label for that because they work similarly, but as far as a specific FDA designation, Zoloft is approved for PTSD. Celexa, in my experience, often works a little bit better for anxiety. And then
Probably Lexapro too.
yeah, then
both of them.
right,
Yeah.
and then Lexapro. So what do you notice between the generic names of Celexa and Lexapro? Yes. Or what about even longer than that? Yeah, citalopram. So if you broke citalopram into two pieces and just took one half of it, it would be S-citalopram. Okay. So it's for that reason works the same. So yes, Celexa, Lexapro both a little bit better for anxiety, but also fewer drug interactions and side effects with the Lexapro. This is all very provider dependent. Very infrequently, I think, would a provider in AHC start a patient on one of these medicines, just because we don't really have that follow-up with them. But everybody kind of has their own preference in what to start with as far as picking one of these drugs.
It's still important to be familiar with this class because many patients are on them. It's very common medication. And just recently, I know we've had, I can think of two recent cases. I know Miriam was one of them. She had and this is what happens with these patients. You know, for whatever they're going through in life, they'll stop these medications, which is equally dangerous in the SSRIs. And so, you know, that's stuff to pick up on in the history. Well, no, you know, I was taking my Paxil or whatever, and then I stopped it. Well, did you stop it because your doctor told you to? And when did you stop it? These medications are tapered to remove them. It's not safe to stop the SSRIs just off the bat. So that's why these are important ones still to be familiar with.
And when you're doing a MedRec, you very well may see all of these on there because they've been on this at one time and this on one time, and so to clean that list up and say, okay, well, Zoloft didn't work for me, Lexapro didn't work for me, now I'm on Paxil. That's why you might see multiple of these things. There really wouldn't ever be a reason to be on more than one of these. Different behavioral health meds, sure, but you wouldn't be on two different SSRIs at the same time. The last one on there, Prozac, that may be the most well-known name. It has the longest half-life, which you'll notice here is written in days and not hours. So this is about 4 to 7 days. So very long-acting. So sometimes this will start to work a little bit quicker because it's gonna the dose is gonna kind of start to stack, and it's also a little bit safer if a person were just to discontinue it abruptly. We don't have to taper this one quite as long, just because your last dose is still going to be working in your system a few days later. And Prozac tends to be a little bit activating. So if Paxil is a little bit sedating, Prozac tends to be a little bit activating, meaning that for patients who maybe have some sleepiness, some laziness, for lack of a better word, that's not a personality judgment, it's just they're going to tell you, I just don't have any motivation, I'm just kind of lounging around, they're tired. This might be one that can help give them a little bit of a boost in the morning. But again, these are all very similar, and it's kind of a Coke and Pepsi. One is going to work for one person and may not for another.
I just was going to mention, we don't have too many occurrences. I mean, I'm just thinking back over the time that we've had adults. I feel like it's not very often, although there have been times when I want to start one in a patient, like a couple of our frequent flyers where I feel this is a big issue. I mostly contact the PMDs for these. These meds also have black box warnings on them. Can anybody know why? What are they at higher risk on when they start these meds?
Particularly young adults and older people.
Suicide.
Yeah. Oh. Can you believe that? There's a depression, so you have a depressed patient. You want to start them on Lexapro. They need to be followed because they have a higher risk, so they usually actually step up the dosing, so they are followed very closely by whoever is prescribing this. Usually they titrate up the dose because they're watching for the side effect of suicidality. Exactly. So that's why, and they also have recommendations to, and I'm sure similar for you, internists usually will keep these medications on for a minimum of 9 months before they start to taper them. So say you have somebody who, is newly diagnosed anxiety disorder or panic disorder or something, you put them on one of these meds, we'll go ahead and do it for 9 months to a year, and then if that person's doing a lot better. So it doesn't mean it's a forever drug for these patients, but they really need to, and just in general, when you're looking at this category, depression, anxiety, PTSD, medications is one side of it, right? There's a lot of other things like behavioral cognitive therapy and whatnot. So these patients are that's why I think in an after-hours setting, we're not often starting these drugs, is because they've got more to it for their treatment. Okay.
That's exactly right. And the reasons that people stop taking this are, one, well, I felt better. Or maybe you felt better because you were taking it. Or I didn't want to get dependent on it. So they'll stop taking it. That's real common with sleeping medicines too. They say, well, I don't want to get hooked on this because if I don't take it, then I'm not going to be able to sleep. And I say, well, but you weren't sleeping before you were taking it either. So sometimes there's still that stigma with behavioral health medicines that you have to remind people that not only do you have to take it and discontinue it responsibly with the advice of your provider, but also that if we're treating high blood pressure or chronic migraines or any of these other things, that requires daily medication to manage those symptoms. So the only way that we have to address the physiology of this, which is a brain chemistry issue among other things, is with medicine. So, but as a class, and these are other reasons that people will discontinue it, but typically it's earlier on. Sexual side effects with SSRIs specifically. This can either be performance issues like erectile dysfunction, meaning the man can't get an erection or maintain an erection, or it might be just loss of libido and loss of interest. So that can affect both men and women. And then anorgasmia, or not being able to finish, is another potential side effect of this. So if I'm a guy, that's going to be maybe fun for like a weekend, right? Because I can go all day. But in fact, for premature ejaculation, sometimes we'll prescribe these medicines to kind of use the side effect of it. As a treatment benefit, but those are sexual side effects is a common reason that people will discontinue. So if ED is the problem, we can put Viagra on top of that, and now you're treating side effects with another medicine. If low libido is the side effect, we can sometimes add Wellbutrin on top of that, which we'll talk about in a little bit. That can improve mood and libido. But for the not being able to finish thing, for men or women, we don't really have a medicine for that. And so that just becomes kind of a benefit, risk, and side effect analysis, or we're going to switch them to one of these drugs that maybe has a little bit lower side effect. Paxil specifically, that one we talked about at the top, actually has one of the higher risks of sexual side effect. But GI side effects are also pretty predominant with these. Usually that's initially, so over the first couple weeks while we're getting used to it. And one of the reasons for that is that these medicines work on the hormone neurotransmitter serotonin. And more than 90% of our body's serotonin is actually in our gut, and so these medicines affect the way the GI system works. So abdominal pain, diarrhea, nausea are all common side effects. And then serotonin syndrome is a little bit more uncommon, and it's usually more frequent in people who are taking multiple behavioral health medicines or multiple medicines that target serotonin. But it can be pretty severe, and this is going to be a person typically with headache, racing heart, sweaty palms, muscle tremors, symptoms like that. The SNRIs is the next one. It's a little bit different, so it targets both serotonin and norepinephrine, the two different hormones, and so their target is a little bit different. They can be used for depression, among other things, but also that norepinephrine part targets the fibromyalgia type symptoms, the chronic pain. This SNRI is actually similar to the way that tramadol and Flexeril are made. So the structure of those, the mechanism of action is similar to this drug category. So it can be used for depression, fibromyalgia, and chronic and or nerve pain. So that's those two other blanks, chronic and then nerve pain. Cymbalta, Effexor. Effexor usually carries a little bit more of the GI side effects. Savella is one that is usually more used for fibromyalgia. I don't see that one too commonly. But if a person has depression and they have chronic pain, then I might start with one of these, or they might be on one of these for that reason. Or fibromyalgia and depression are often present in the same patient, so these might be a drug choice that you would start with. And then some other ones, the bupropion that we started talking about in the beginning of the case, is just for depression, whereas some of these other ones can be for depression or anxiety. Bupropion's typically not for anxiety. It can be a little bit activating, so it can make anxiety and panic worse. But it has fewer GI side effects than the SSRI. It also has almost none of the sexual side effects. So fewer sexual side effects. Maybe if somebody's tried a couple SSRIs and that's their main complaint, then you might try them on Wellbutrin. It can also be used for smoking cessation. Bupropion, like these others, affects serotonin, but it also hits a little bit more of the dopamine, which is the kind of the pleasure hormone. So that's one reason we use it for smoking cessation. And then prazosin, that was right above that. Minipress is no blood pressure medicine. We don't use it much for that. This pretty commonly I see in the active duty population. It's used for a common complaint with PTSD that we don't want to take a guess. This is a a sleeping issue, something that wakes people up frequently. Nightmares. Yeah. So pretty frequently you'll see folks with PTSD on a Zoloft and a Viagra and a Minipress, and then also probably something like an ADHD type medicine, especially if they've had a TBI or a brain injury, because sometimes TBI and PTSD work on the brain kind of similarly to an ADHD type thing, with difficulty with focusing on that. So. But anyway, yeah, prazosin's for nightmares. How
It's an
about
alpha blocker, so you can also see it in like older males, usually for like urinary problems. But that's interesting about PTSD.
Alright, so we're going to try to get through this page here and then leave the rest of it for next time. But Zofran at the top there, little dagger on there for increased risk of arrhythmia. It's actually a relatively low risk with this one, but I have seen it happen once in the OR. An older woman in her late 60s came in with some nausea related to whatever her complaint was. She was given some IV Zofran, and on the monitor you watched her go into torsades, which is this irregular rhythm, and then she ultimately ended up requiring CPR and an ICU stay. So this actually, one dose of IV Zofran, which is typically seen with higher doses, and if it's pushed too fast, but still she got an appropriate dose of it. But she was on some of these other medicines that caused that. So we think, oh, just give her 4 milligrams of Zofran. It's not a big deal. For her, it was a big deal because she died. She was resuscitated, but it still stopped her heart. So don't use this in pregnant women. It can be used. I had one pregnant patient that was on Zofran, Phenergan, and Reglan all. She was admitted 3 times for what they call hyperemesis gravidarum, which means just intractable nausea and vomiting. She didn't gain any weight in her pregnancy until 3rd trimester because of that. But so just as a rule,
It's only done in the hospital.
Yeah. Just as a rule, don't use this for pregnant patients. There's some risk of birth defects in first trimester, which is typically when women are going to have their morning sickness. So I put targets on there. Just these all, it's not strictly one hormone that these work on, but they're just some differences. So this is a serotonin drug, like we've been talking about, so that targets serotonin. Promethazine or Phenergan, which we also have in the clinic, is it targets histamine. So when you hear or think of histamine, I want you to think of sedating. Histamine stuff like antihistamines like Benadryl makes you tired. Phenergan, that's going to make people sleepy time too. It can be given by mouth. They're also rectal suppositories. Sometimes we use this for an adjunct to migraines. So sometimes if someone's too nauseated to even take a pill, then they can do a suppository instead. This can be given IV technically, but even if the patient has an IV, it should still be given intramuscularly. There's a risk of scarring the vessels if it's given through an IV. And then Reglan's another good nausea medicine. It can cause an involuntary movement disorder because it hits dopamine, targets dopamine, so we've talked about that before. So if you hear dopamine, I want you to think pleasure hormone, but also movement. So medicines like this, like antipsychotics, or diseases like Parkinson's, those affect the brain's dopamine parts, and that's why it causes involuntary type movements, or tardive dyskinesia is the specific name for that. But it's a promotility agent, meaning one of the ways that it helps with nausea is to help empty the stomach. So if someone has acute gastroenteritis, this may not be the best option for nausea because it'll probably make their diarrhea a little bit worse. And then when I was making this antibiotic list, it just kept getting longer and longer, but these are all so different that it's kind of important. And I also think this would be relevant for you just understanding maybe some of the treatment decisions we make. And when patients come in and they say, my kiddo's been on this medicine and is still having a fever or whatever it might be, it's just kind of helpful to know. So azithromycin we talked about in the case, very commonly prescribed for upper respiratory things. Typically it should not be, but it can be used for that. But it's also usually the go-to or the first line for pneumonia, for community-acquired pneumonia in healthy adults without underlying lung disease, so Z-Pak. And then we also use it to treat, this is something we'll see in clinic probably, we give 1 gram once to treat the drippies. Not nose drippies, think further south.
So chlamydia.
Chlamydia, yeah. Chlamydia, 1 gram once. This can come in a slurry, powder that you mix in, it tastes terrible, or they can take a dose of it. Azithromycin can also be used to treat infectious diarrhea and traveler's diarrhea, but I didn't put that on there. Gonorrhea and chlamydia like to hang out, so that's the next one on the list. If you're treating gonorrhea, you're also going to get a dose of azithromycin. Plus this drug here, okay, ceftriaxone or Rocephin. So you may know the dose of that to treat gonorrhea. 250 milligrams IM. So let's say you were to treat somebody, if you have somebody, test has confirmed they only have chlamydia, they just need azithromycin. If somebody has gonorrhea, they need both. Even though, there's a little factoid for you, azithromycin is going to treat and cure about 90% of gonorrhea, but the treatment threshold requirement I think is over 95%, and so even though 90% is pretty good, that's still why we add the Rocephin onto it. There's gonorrhea that's becoming resistant to treatment, and so it gets kind of that double treatment. Patients with gonorrhea more often are going to be symptomatic, but not always. Chlamydia very commonly is going to be no symptoms. Ceftriaxone or Rocephin is also used to treat more serious infections like kidney infection, sepsis, meningitis. If someone comes in and needs a quick dose of something, we'll usually oftentimes give them a dose of Rocephin IM, usually about 1 gram, or in an IV 2 grams. And then Amoxicillin, which is in that penicillin family. It's similar to ceftriaxone as far as the structure of the drugs. Pretty much amoxicillin I want you to think of as a pediatric drug. That doesn't mean it can't be used in adults, but most commonly for the ear, nose, and throat, lung infections in kids, you're going to see amoxicillin. And then amoxicillin plus clavulanic acid is called Augmentin. It can be used for the above things anywhere you would use amoxicillin, but it's the first line choice for bacterial sinusitis. So this is not a person who's come in with a stuffy nose for a week. This is a person who usually is near or past a week. They also have heavy green stuff coming out of their nose, facial pressure, fever sometimes, or if somebody's had sinusitis that's been hanging on for 2 weeks, sometimes they'll still treat with that. Dogmentin is the little funny name to remember. We use Augmentin for dog bites and even human bites as an antibiotic to prevent infection. And then also this came up the other day, it's the preferred drug for perianal abscess. So skin abscesses we usually treat with different medicines, but if it's particularly in that area, this is going to better cover anything that would be coming out of the GI tract. Keflex is similar to Rocephin. We use that to treat skin infections that are not MRSA. And then Keflex, it can be used for other things, but also as an alternative for a UTI. And again, you'll see a lot of these things used for other things and alternatives to these things used, but just as kind of a general class, this is to give you an idea of what these medicines are for. Doxycycline is a very versatile medicine. Photosensitivity is kind of the main side effect that we have to counsel people on, in addition to some GI upset and even some inflammation in the esophagus, but you can get more photosensitive to this. It's an alternative treatment for chlamydia, but rather than taking one dose of azithromycin once, you take this for 2 weeks. And it's also an alternative treatment for pneumonia, sinus infections, and can be used to treat MRSA skin infections too. So this is an example of where the guy in our case who had all these other contraindications to a medicine like azithromycin, maybe after you came and told me, hey, doc, this person's on these other medicines that might interact with azithromycin, what do you think about that? Then I might say, oh, hey, Molly, good catch. Maybe we'll give him doxy for his pneumonia instead of azithromycin, to give him one less medicine that could cause that arrhythmia. You know, same thing with up above. We gave that guy Zofran. Maybe we give him some phentermine instead. He's not going to, a little bit extra sleep, it's not going to hurt him if we send him home with some phentermine. Macrobid is not an antibiotic in the same sense as these other ones. It's more of an antiseptic, meaning it's going to concentrate in the urine. It doesn't really absorb well into tissue, and so really the only thing we use Macrobid for in practice is UTIs. It's always the first choice for uncomplicated UTI, and then I put usually. Okay, there are always exceptions to that, but in a young, healthy woman that doesn't have a reason to not take this, and you don't think it's spreading past the bladder, Macrobid's a good first safe choice. If they've had urine cultures previously that show the organism's resistant to Macrobid, then maybe you wouldn't start with that, but still for most uncomplicated, it's a good choice. And then Septra or Bactrim we can also use for soft tissue infections, skin infections. It does also cover MRSA. And then another nice thing about that, I'll use this in the field setting a lot for UTIs, is because you only need to use it for 3 days. You can extend that for longer, but 3 days of Septra will usually take out UTI. Clindamycin, also good for soft. It's also really a diverse medication, but it's good for skin and soft tissue infections, including MRSA. And it's an alternative for ear, strep throat, dental sinus infection. So let's say somebody has an anaphylaxis, a severe reaction to penicillin. We're not going to give them that. And even because of that severity of reaction, most of those cephalosporins, the ceftriaxone, cephalexin, we're also not going to give them because of that severe risk. So then we'd be looking at something like clindamycin maybe to treat their ear infection or their strep throat or whatever. Another nice thing about clindamycin is that the by mouth is as quickly available as the IV or the IM form. And so if you have somebody in clinic and you need to get them a dose of something quickly, this is going to be basically as effective as if you were to give them an IM shot of it, which you can do. The clindamycin can also be given intramuscularly. And then the last two here, Cipro, you'll see that's an increased risk of seizures, which I didn't know. Cipro's in a class of antibiotics called fluoroquinolones. Fluoroquinolones have kind of fallen out of favor. There are some specific indications for them, but the guidance really now is if there's any other alternative, use that. In addition to this seizure risk, there is behavioral health risks, psychotic risks, blood sugar issues. It can cause tendon rupture, so Achilles tendon specifically, but it can make tendons rupture weaker. And this is even within the first few days of use. This isn't like I've been on Cipro for a month, not that anybody ever would be, but it seems like every couple of years they come out with a new warning about these medicines, and so they're just in general, they've kind of fallen out of favor. But you will still see a young, 20-year-old woman that comes in with an uncomplicated UTI and they get Cipro. And not for necessarily any reason other than that's just that provider's preference and that's what they've always done. But there are actual tangible risks of using this medicine, and so that's why I put never first choice for UTI. And then I put usually. So maybe they have a UTI and just got over a UTI and their culture was resistant to a bunch of things, so they need Cipro. That's totally fine. The risk of not treating them is obviously worse, but I consider this the first line treatment for pyelo though. So if somebody comes into clinic and they've got pyelonephritis or this urine infection that's up to their kidneys, typically they're going to have flank pain and fever and nausea and feel pretty miserable, but not always. But those would be a person who would usually get a shot of Rocephin, and then also I would start them on Cipro outpatient. Like I said, there are other reasons that Cipro can be used, but it's just no longer kind of in vogue to do that. But let's say an older person comes, it doesn't have to be an older person, but it's more likely comes in with some new ankle pain and they've been on Cipro for a week for their UTI, you're going to be more likely to consider a tendon rupture in that person than you would have been otherwise. So that's just another reason that getting a medical history is important. And then the last one on this list, and then we'll be done, is Flagyl, metronidazole. There are a few things that this works for, but when we do a hanging drop test, bacterial vaginosis and trichomoniasis both are treated with this. And then also giardiasis or giardia. So if you're out drinking out of streams here and you get a little protozoal infection, it would also help to treat that. But the one thing you have to make sure to tell people, and this is for even a couple days after they finish treatment, is they should not drink what during their treatment? Alcohol, yeah. Can make them pretty sick.
Well, everybody knew that.
Yeah, good. You've been so
There are a lot of
counseled.
people on Flagyl before.
Can I drink alcohol with this?
Just kidding.
But Flagyl, you can use either a PO or a vaginal gel for that. I had one girl, I diagnosed her with BV. Her birthday, her 21st birthday was on July 4th.
Oh, goodness.
And her 7 days ended on July 2nd. So I said, okay, you'll be fine. But anyway, she was almost bummed out.
Oh.
That was awesome, Andy.
Yes.
Yeah.
Thank you so much.
Thank you. You're welcome. Thank you for your attention.
We'll be looking forward to part 2 of this
Dieu.
part 2 of this presentation.